right, well, thank you very much. I'm thrilled to see the talk is up here. We've had some issues downstairs, but here we're all good here. So a few disclosures that I'll just note here. So a couple questions that I want to try to answer in these 6 minutes here. How do we treat patients who do not respond to laser as well as expected? And what comes next for these patients, both on the medical and procedural side? So let's jump into that. So there's not going to be any controversy between Dr. Geronimus and I for these first couple slides. Early treatment, we know that even if we have a patient who theoretically should be more challenging, if we start with early treatment, we're going to get a better result. This is a patient I saw many years ago. She had, I don't know, probably 14 treatments in her first year of life kind of thing. She got dramatic clearing. You'll notice that I did not treat her eyebrow because we wanted to preserve that for her. But she does periodic treatments, maybe 2 a year. We've been able to maintain it. She also already had some hypertrophy when she was born, but that has not progressed. I also think persistence in port wine birthmark treatment. This patient has had a number of treatments. You can see he's got quite a dark and nodular and hypertrophic port wine birthmark, but just multiple treatments over time, and he did not start treatments till he was in his 50s. So it is possible, but it just takes persistence, and sometimes we can use different wavelengths and things like that. That's what I wanted to say here. Here's kind of a lineup. This is a number of years ago when we had multiple different pulse dye lasers, but you can use different wavelengths, 595, 532. Some people use intense pulse light. We can vary our pulse duration. We can and overall, with all these things we can change, we can get optimal results. Now keep in mind, we know from OCT, which I'm going to show you in just a minute, that these port wine birthmarks are very diverse. Each spot is different, and certainly between each patient. Now, I do think, though, that there are some new devices that are coming up that are going to be allowing us to try some new things. This is a long pulse 532, has cryogen spray cooling. It also has a 1064 nanometer on it. And you'll be hearing more about this, but it's got some interesting characteristics. One is that you can either do a single pulse, you can do sub-micro pulses, or you can do sub-milli pulses. This is something I think we have to learn a lot more about. I've been trying these different settings and things like that. I do think I can achieve equivalent result with the long pulse 532 that I can achieve with the 595 nanometer pulse dye laser, which I have used for decades now. But my hope is that when we have more of these parameters that we can change, that we'll be able to get even better results for patients. And this is just quickly showing you the equivalent results that we've been able to achieve with patients. You really can't tell which device was used where. This is a patient that we used the long pulse 1064 on. She has previously had surgery to cut out this malformation, and then now she has some residual vessels, and we've been treating those, and she's actually been very pleased. Now, I mentioned optical coherence tomography at the beginning. I think of this as ultrasound, where we can, but we're using light, and then within 30 seconds, we can get a superficial plexus depth, we can get a mean or modal vessel diameter, and we can get our vessel density. And we have been doing these large mappings, so 20 pulses or 20 areas in patients. We can also look at the individual depth, so we can look at 0.15, 0.2, 0.25 millimeters, and look at vessels at each of these depths. We've also found that each individual is different, so we need to do a control area or an uninvolved skin area and then make a ratio in order to get the information from this. There's a lot of information we can get, but just as a really quick summary, we have found that most of the port wine birthmarks, the highest blood vessel density is in the more shallow depths, 0.15 to 0.2 millimeters. So it may not be that for every patient we need to use deep depth. 532 or 595 may be very good for most patients, and I think many of us have experience with that. We did find that the flat lesions seem to have higher density of blood vessels in more superficial areas compared to lesions that were hypertrophic. So then again, there may be a reason why we'll want to use some longer wavelengths for those hypertrophic lesions. I think this is all very good, and I think, of course, we want to optimize our treatments, but I also think we need to think about what comes next. We've tried a variety of different medications throughout the decades, many of them presented here at the ASLMS meeting, those including rapamycin and imiquimod. People have tried timolol. And these medications were anti-angiogenic, and people got some improvement, but really not the home run that we were looking for. I really think we need more research. We know that for port wine birthmarks, the majority of them have a GNAQ mutation in the endothelial cells. And what we need is the medications that are going to target this pathway, and it's likely going to be long-term therapy for patients. Perhaps we will move some of our vessels, hopefully with our optimized treatment, and then we'll have a medication that will maintain it. Perhaps think about angiofibromas with tuberous sclerosis, something like that. But if you stop the medication, it would likely come back. So in summary, there are a variety of ways to approach resistant lesions. We have our non-invasive imaging. We have a variety of different wavelengths and devices that we can use. But I really think for the future, laser in combination with medications is going to give us a better result. Thank you very much. There's much work to be done, and I appreciate you listening.